You're watching Baptist Health's Resource Live, where our respected experts bring you timely and practical health and wellness information to improve your family's way of life. We're healthcare that cares. This is Resource Live.
Hey everyone, I'm Dr. Jonathan Fialco, Chief Population Health Officer for Baptist Health South Florida, coming to you live from the Baptist Health Newsroom. A stroke can happen to anyone, anywhere, at any time. Stroke is the fifth leading cause of death in the United States, but the leading cause of disability, which concerns people more. Stroke deaths are preventable. The ultimate success of stroke care depends on one factor: time. May is National Stroke Awareness Month, and there are a handful of experts that are here today to share their experiences and expertise with us. I'd like to welcome Dr. Leo Nguyen, Chief of Emergency Medicine at Baptist Hospital. Welcome, Leo.
Thank you, Jonathan.
Dr. Felipe de los Rios, Director of the Stroke Program at Miami Neuroscience Center. Thanks for being here, Felipe.
Thanks, Jonathan.
And Dr. Brian Snelling, Chief of Cerebrovascular and Endovascular Neurosurgery and the Director of the Stroke Program at the Marcus Neuroscience Institute. Please welcome, and thank you, Brian, for being with us as well.
Thank you for having me.
Great, so please welcome this group of experts. Before we dive into today's subject, I want to remind all our viewers to send your questions and comments throughout the segment. We're here for you and happy to answer any of these questions you may have. So let's get started with the dialogue, and I'll turn it over to Brian first. Brian, big question. Tell us, what is a stroke, and maybe get into a little bit the different kinds of strokes.
Yeah, exactly. Quite simply, a stroke is a disruption of blood flow to the brain, and that disruption of blood flow deprives the brain cells themselves of oxygen, which can lead to the death of those cells over time. And with regards to the different types of stroke, there are really two main types of stroke. There's ischemic stroke, where there's a blockage of blood vessels deliver blood to the brain. And then the other side of that, there's what we call hemorrhagic stroke, and those are bleeds that can occur in and around the brain.
Is one more common than the other between the ischemic, the block of blood flow, and then the hemorrhagic, the bleeding kind of stroke?
Yeah, ischemic stroke is overwhelmingly more common. It makes up around 5 out of 6 types of stroke. So out of 6 people come to the hospital with a stroke, about 5 of them will have what's called an ischemic stroke.
So the treatments are different, obviously, and the approach is different based on the kind of stroke. It's important for us as practitioners, especially if we're going to prevent strokes, to know what causes a stroke. But if someone has a stroke, is there a differentiation in the way the stroke affects them, whether it's a hemorrhagic or an ischemic stroke?
Yes, there certainly is. Ischemic strokes can certainly have some specific symptoms that we'll touch on in a little more detail, I think, later on. And hemorrhagic strokes can have a couple different kinds, and they can present a little bit differently. So there is some nuance there. The most important thing is that we'll touch on the signs and symptoms to be aware of, not only how to prevent them, but if you do recognize that you or a loved one or a friend is having symptoms of a stroke, what to look out for and how to get the best care as quickly as possible.
So I appreciate that, and we will be getting into quite a bit about the symptoms and signs of a stroke and what to do if you or a loved one expresses those kinds of concerns. Let's switch gears a little bit to Felipe. We know that we want to minimize the damage of a stroke, but going back to the overarching prevention, what are the risk factors or things that may make someone more likely to be at risk for a stroke? And more importantly, what can we do to decrease the risk of stroke as a population?
Yeah, no, that's prevention is key. I think repairing the brain is not easy, and many times we're able to help, but you want to prevent it in the first place as much as possible. And the good news is that stroke in general is 80%, has been calculated to be about 80% preventable. So there's a lot of things that we can do to prevent a stroke. The other 20%, there's some genetics involved, environmental factors. There's things that are out of our control, but most of it we can help and ourselves reduce our own risk of having stroke. And some of these things are common to coronary cardiac disease, things like high blood pressure, high cholesterol, lack of exercise, having a healthy weight, checking for and treating diabetes, avoiding tobacco, vaping or otherwise, alcohol, recreational drugs. All those things can help us reduce our risk of having an event.
So I think that's well said. The same factors that might be in play for cardiac outcomes is the same for cerebrovascular stroke outcomes. And in fact, it's important, I think, for the listeners to know, if you have these risk factors, you may have a stroke or a heart attack. You can't say you're going to have one or the other. So it's the same prevention type of strategies to decrease the occurrence of these.
Yeah, and especially in midlife, Jonathan, because many, especially young adults feel like everything's going for them. They're at no risk, or feel like they have no risk themselves at that point in time of having diseases like these. But the truth is, if you care for your arteries in midlife, starting in midlife, then you're going to be well set for older age without these complications. So it's good to start early and going to get your routine checks through your primary and making sure you don't have these risk factors. And if you do, that you control for them.
I often tell my patients, when you're in your 20s and 30s, you're going to live forever. In the 40s, you start paying attention. In your 50s, you say, well, why didn't I do that when I was in my 30s and 40s? So start early, and you can actually lay a good foundation for better health as you get older. Leo, going back to now the 800-pound gorilla, what would be warning signs of a stroke? Because we do want to get into the concept of getting people recognized and treated as quickly as possible. And then what would be the more definitive signs of a stroke?
Yeah, so we see stroke presenting in the ED very, very often, and early detection is key, obviously. So sometimes the symptoms are very obvious. It's either numbness or weakness on one side of the body. It could be visual loss, either one eye or both eyes is important. Speech problems, trouble speaking or slurred speech. It also could be more vague symptoms, something like dizziness or sudden onset of confusion, trouble walking, things as such. And those go for both the ischemic and hemorrhagic stroke that Brian alluded to earlier. The slight difference in hemorrhagic stroke, many times it's accompanied by a headache. So a lot of times you have a preceding headache and then neurological deficits and headache during the onset of symptoms. So it's a wide range of symptoms. I think the key is a sudden change. If you see a sudden change, I think we all have to pay attention.
Felipe had one of our previous resource sessions had mentioned that especially with a stroke in particular, you lose something, you lose a function, you lose the ability to move or sense something, things like that. In the interest of not scaring people, in a sense, most headaches are not hemorrhagic strokes. Most little weakness you might feel could be a numbness in a nerve or something like that. But on the other hand, we don't want people to ignore these symptoms. Can you give any guidance about when you should activate a more serious evaluation for these symptoms? Is there any perception that you can give to people that might say, hey, this is serious, call 911, or can you explain it with something else? It's kind of a loaded question, but I want to make sure we don't make everyone think every time they have a symptom, it's a stroke. Leo?
Jonathan, are you asking that for me or to Leo?
Doesn't fall to Leo. My bad, guys.
That's all right. That's okay.
Oh, for me, well, to me, I think early evaluation is critical. Because I think the mistake is trying to see if it goes away, and sometimes you do that and you lose time, and losing time you're losing essentially neurons. So I think the early thing is getting an early evaluation if you're unsure. So the common mistake is let's see if it goes away, and then they come in several hours later and time is lost.
Fair enough.
I will add just two things to that, Jonathan, if I could, to what Leo had said. One of them is headache plus something else. So you have headache plus weakness, numbness, something else. That's a very concerning red flag. And then the other one is what we call worst headache of life. So if it's a headache that is the worst headache you can possibly imagine, almost unbearable, then you have to go to the emergency room right away.
And I can echo that. I remember I was 11 years old, walking up, coming home from a breakfast with my father, and he stumbled and had the worst headache of his life and had a cerebral artery aneurysm, which ruptured, survived. It was a complicated course, but that's exactly just suddenly this most incredible headache. So certainly pay attention to that and get checked out right away. And we'll talk about how to do that as well. Brian, switch gears again a little bit for a second. We talked about risk factors, and of course, what's these are risk factors for cardiovascular disease, stroke, heart attack, cancers, various other things like we talked about. But something that's really coming under great scrutiny is stress, certainly in the COVID environment and with our current societal stresses. And we know that depression, anxiety, and other behavioral aspects can increase the risk of stress. Can you talk a little bit about that interaction between stress, depression, anxiety, and stroke, and of course the importance of recognizing and managing those stresses?
Yeah, certainly. Those are sort of a newer category of things that are not classically associated with a risk of stroke, but there's mounting evidence that stress, and certainly that would be like work-related stress, does have some association with developing stroke in adults. And there's certain studies that have come out that have shown that association. So while the evidence may not be as strong as it is for other things, or the risk factors that were mentioned, we're starting to see that association and know that that's something that if it can be modified, that it should be modified.
So similar to other risk factors, it means pay attention to these things, recognize it in yourself, and look for resources or ways of mitigating those risk factors to increase these risks, which is well said. Felipe, again, we've intersected multiple times over the past year. And let's talk specifically about COVID-19. I mean, COVID-19, I remember a year ago, we were seeing cardiovascular concerns, cerebrovascular concerns, strokes. What have we learned over the past year regarding the interaction between COVID-19 illnesses and strokes?
Yes, now we have more data, and there's different sources. The AHA, the American Heart Association, has a COVID-19 registry, and then some data was presented in the stroke conference this year. And the good news is that, I mean, even though it is associated, COVID-19 infection is associated with stroke, the risk is really small. It seems like about 1.4% of patients that have symptomatic COVID-19 would or could experience an acute ischemic stroke. So the vast majority of people don't. And we do know from other infections like influenza-like illnesses, even urinary tract infections, that the risk of stroke does increase in general when your body is battling an infection. The risk might be larger with COVID-19. It's a little bit uncertain, but the overwhelming majority of people do not experience this. And what we've seen is that those that do experience a stroke not only can have ischemic strokes, but it can also have bleeding. So normally, like Brian was saying, the ischemic stroke is about 80% or so. When we talk about COVID-19, ischemic stroke is about 50%, and hemorrhage is about 34, 40%. So there's a possibility of both events. But again, for most people, stroke is not on the radar if there's COVID-19.
So COVID-19 has been found to affect pretty much every organ in your body and every disease in one area, one way or another. But stroke has become less of a concern regarding the acute COVID issues over time. Can you speak a little bit about, there was one of the vaccines had a slight incidence of reporting of a certain kind of blood clotting and the cerebral venous sinus thrombosis. Can you just elaborate on that a little bit, what that is? And is it something that we should really be concerned about when we look at our probabilities of side effects of the vaccines?
Yeah, I think it's good to put things in perspective and understand the difference of stroke and this sinus vein thrombosis. So stroke are clots or blockages on the arterial side, And when we're talking about these veins, clots on the veins, it's on the drainage part of the brain, especially when we talk about sinus vein thrombosis, also on the veins as the blood leaves the brain. And the risk has been found to be very, very small. So this has been noticed with the Johnson & Johnson and also the AstraZeneca. It's about 1 per million, maybe a little bit more than that, but extremely rare event. At baseline, generally in the population, this happens. The sinus vein thrombosis can happen. And the baseline frequency is about 1 per million. So it's very, very close. We haven't seen that with the Moderna or Pfizer vaccines. So there might be something specifically to the other two. But just to put it in perspective, oral contraceptives, for example, have been shown to increase the risk of thrombosis as well, and sinus vein thrombosis too. And the risk with that is about the odds ratios are likely of having a vein thrombosis with oral contraceptives is about 8 times your normal ratio. So it might even be bigger, your risk with oral contraceptives than with these vaccines. And we still obviously recommend those as a contraception method. Additionally, I would say that there's treatment for these conditions. There's specific things that you can do to treat sinus vein thrombosis when it happens. And the risk of having sinus vein thrombosis from COVID-19, which there's also risk from the infection itself, seems to be 10 times higher than the risk of getting thrombosis from the vaccine itself. So you're preventing having this complication from the infection by using the vaccine.
So I think that's a great way to explain probabilities. We tend to be afraid of things that are less likely and not recognize the benefits of what something like the vaccine may be. But the reality is none of us are recommending to avoid a COVID vaccine because of the risk of the central venous sinus thrombosis.
Exactly.
So I appreciate that. Leo, lots of movement, and it's been accelerated in the COVID environment towards using technology, tools at home, monitoring, apps, virtual care. Can you speak a little bit about what your experiences are and where do you think things are going regarding stroke assessment and prevention opportunities and access with using technological tools that we have available now?
Yes. So we use technology from the entire range of stroke care. So even from the patient side, the wearables and the watches, I've seen several patients that have come in with an irregular heartbeat from an Apple Watch, and it ends up being atrial fibrillation. And atrial fibrillation is an irregularity of the heart, and it's a strong risk factor for stroke. So I think that's important. Additionally, access to care. We talked about the early warning signs, and sometimes patients are unsure. So to leverage the technology and use telemedicine, which has increased in usage with COVID-19, I do not think it's a wrong thing. I think it's a good thing, actually. So as long as the patients have access to care and using technology is great, and all the way to arriving to the hospital and the diagnostic and therapeutic modalities that Felipe and myself and Brian use on a daily basis. It's always evolving, and our goal really is to diagnose quickly as well as treat quickly as well.
I mean, down the road, we'll have sensors in people's houses. We'll be able to manage, we'll be able to pick up variations in temperature and heart rate and respiratory rate, sometimes before people even feel something. So that's kind of interesting to see where that's going. But I appreciate that. Access is important. People 24/7 can get someone on the phone. Baptist Care on Demand is an example to assess their symptoms if they're not sure. The wearables picking up arrhythmias can determine people who might be at risk. An embolic stroke is a blood clot in the heart that travels to the brain. It's a kind of ischemic stroke, not as common as the blood vessels in the brain closing up, but these are all the types of things we can use to impact those bad stroke numbers that we've seen before. So again, great information. Brian, now let's go back to a couple of more cogent, acute types of things for the patient. So ask you a couple of questions regarding whether these things make a difference in one's risk of stroke. Is there a difference between men and women, for example? Is there a gender differential in who's at risk for stroke?
Yeah, women are at an increased risk of stroke compared to men, and that's both ischemic stroke, and then especially also when we look at things like subarachnoid hemorrhage or the aneurysm rupture, they're at a higher risk as well.
And then we also noticed birth control pills, while not to be avoided, the risk is low, but they can have a slight increased risk as well. So some of that could be there. How about race? Do we see anything different between African Americans, Asians, Caucasians? Is there any race-related differences that we've been able to identify?
Yeah, certain races are at a higher risk for stroke. Those would be African Americans, Hispanic race, Asian American, Pacific Islanders. Those races would be at a higher risk of developing stroke compared to others.
And again, it might be genetic, it might be cultural, it might be lifestyle, but we're definitely seeing these trends in the different populations. It was mentioned that there are some relatively rare genetic abnormalities that can lead to strokes compared to more general lifestyle risk factors. But if a family member has a stroke, a first-degree family member, does it make someone else more likely to have a stroke?
Generally, yes. And then even specifically, again, but my personal bias is towards things like brain aneurysms. And it's certainly, we know if someone has a family history of a brain aneurysm, or they have 2 first-degree relatives, that puts them at an increased risk. What I like to tell my patients is that family history is the poor man's genetic test, and there's a lot multifactorial component to stroke in terms of the multiple gene interactions that may be taking place. And until there's a comprehensive genetic analysis that tells us what that exactly is, the best thing we can do is just take a really accurate family history.
So if one has a cerebral artery aneurysm, whether it's found incidentally and never bled, or there is a bleed, what are the general recommendations? I know this is, again, personally, as I said, I know this is a a little bit of a sensitive area, but what do we recommend the family members to do?
Generally, it's two first-degree relatives. So a first-degree relative is a sister or brother, mother, father, or a child. And if there's two first-degree relatives that have a brain aneurysm or have a history of a brain aneurysm that's bled, what we call subarachnoid hemorrhage, then they're recommended to have a screening study, which is usually you can do that with a MRA, which is a special type of MRI, no contrast, no radiation, that looks at the blood vessels of the brain.
Great, but main point is ask your doctor, get checked out,
Yeah.
which I think is the main point. All right, let's get to some final points before we take some questions, and this is perhaps the most important to all of us, having to do with what one should do if they or a loved one has stroke symptoms and why it's so important to act quickly. So Felipe, someone's having a stroke, the symptoms we talked about, worst headache of their life, transient difficulty of speech, weakness of an arm, etc. What should one do?
Yeah, if there's any suspicion that someone is having a stroke and that person might not be aware, so you rely on what others might see. So it's good for everyone to know what the signs or symptoms of stroke are. But if there is a suspicion, you really want to call 911 and not just drive to the closest emergency room, because not all emergency rooms are equipped to treat acute ischemic stroke patients. So there's actually certifications. And you can, the hospital and emergency room can get certified as different degrees of stroke expertise. And if you just go to the closest emergency room, you might not be going to the right place. So calling 911 is the way to go. And that pre-alerts the hospital staff of what's happening. And then we're able to give treatment, be that a medication that destroys the clots or endovascular neurosurgery, and try to preserve as much brain as we can. But literally minutes count. The more we delay, the less probability of a great functional recovery.
So 911, don't get in the car. Do you find most times the person experiencing the stroke is aware of it, or are there circumstances where family members may see it or notice it and the person may not even be aware of it or not thinking it could be a stroke?
Both. We see both. I would say probably about equally. I don't know what Brian and Leo's experience has been, but there's cases even where neurologists have a stroke and they don't realize that they're having a stroke, because it's not that they don't know what the signs or symptoms are, but the area of the brain that's being affected prevents them from realizing that they're having those problems. So I see about equally where family members bring and say, hey, no, something's off, this is not right. And the patient is not really aware that they're speaking slurred or having problems with balance. And others where the patient themselves pick up the symptoms and they call 911.
Brian, to that end, do you ever see patients who were reluctant to get taken care of, call 911? Family member insists and fortunately helps and saves them?
Absolutely. Calling 911, calling EMS at any of the signs we previously mentioned is of the utmost importance. Only a minority of the types of stroke actually are accompanied with a headache, or so most of them are painless. And what I usually try to inform patients is that unlike a heart attack, there's really no impending sense of doom with a stroke. It's like Felipe said, it's a loss of something. It's a loss of function. And a lot of people, whether they don't recognize it or they just try to ignore it and think it'll get better on its own, and just to clue people into the signs and symptoms of stroke and let them know that most of them are painless. It's a painless loss of function, and that they shouldn't try to get to the hospital. They should call 911. And another reason to call 911 that I think is a great one is, as a health system, we're equipped as hospitals to receive patients that are coming in with stroke symptoms. So if you're picked up in the field by EMS, they can call ahead and let us know, as opposed to driving in. So when time is critical and time is brain and those minutes count, you're shaving time off of your treatment by calling EMS, because they'll let us know and we'll be able to meet you at the door.
So again, a great point, and that leads right into a question to Leo. From an ER standpoint, not infrequently, a person's coming and on their way with a stroke, which allows you to be prepared. So speak a little bit, Leo, about this final most important point. We say time is brain. Why those moments, those minutes can actually be critical in getting assessed and treated.
Yeah, absolutely. So just the points that Brian and Felipe brought up, I think are critical. I mean, the family paying attention to understanding something has changed and reacting is critical, because if there's a delay, just a deep dive into the numbers are pretty staggering. Every minute, 1.9 million neurons die during a stroke. billions of synapses, which are the connections between neurons, are lost, and they're lost forever. And lastly, which is an interesting fact that I've learned, is for every hour that's delayed, it's equivalent to about 4 years of normal aging of the brain. So the important thing is, and we've seen it numerous times, with the family really saving a life of being on the phone with our loved one and kind of hearing a little subtle difference in their voice and reacting. And that immediate reaction is critical to save the patient's life, as well as brain function.
So again, great points, guys. Hopefully the listeners get a better understanding of why the early recognition of a stroke and stroke symptoms is so important, and not to delay, and use whatever resources you have to get checked out. And if it's certainly these active symptoms, call 911. Don't mess around. Let's take a couple of questions before we have some final wrap-up questions for you guys. I'll direct this one at Felipe. Can you describe the difference between a paresthesia and a stroke? If someone wakes up in the morning and their arms are a little numb and they have some neck problems, so can you talk a little bit of the difference between a paresthesia and a stroke?
Yeah, paresthesia is a symptom, and that can be caused by different things. But when we think about paresthesia, is this tingling that people can have if you've been sitting, for example, too long in one position, and kind of your leg goes to sleep. There's this tingling sensation that can be caused by different things. One of them is pressure, and that's, I think what most people feel. If you're laying over your arm for too long, you will feel tingly for a little bit, and it will improve quickly once that pressure is relieved. And it can be mostly when we think about stroke, we think loss of function. So most of the time you don't get that tingly sensation, rather you have loss of sensation. So you have numbness more than tingling. But any such symptom that is new, sudden in onset, that's not going rapidly away, specifically with the tingling piece, I think is worth getting it checked out. But the symptom that's more reliable or more related to stroke is loss of sensation. So numbness, like when you get lidocaine or anesthetic when you're going to get a dental procedure, that loss of sensation, I think would be more of a stroke specific symptom.
What about, what are the visual complaints that one might be concerned about with a stroke? Felipe, can you just follow up on that one?
Yeah, of course. So loss of vision, it would be the number one, the most common one. You can have loss of part of your vision, so you don't see, for example, the left side of either eye, or you can have complete loss of vision of one eye. With peripheral vision, the side vision is a little tricky because people might not realize, unless they're like bumping into things, they don't see part of space, and then all of a sudden they're bumping into spaces. That's why also you should call 911 and not drive to the hospital, because you might have weakness of an arm or a leg or slurred speech, and you don't realize that you're not seeing properly, and you might get into an accident. So visual field problems can be hard to pick up sometimes, either by the patient or sometimes by the initial evaluation at the hospital, because you have to do it a detailed examination. So it's usually painless, loss of vision, and then you have to go to the hospital right away, because there are treatments that could save that vision.
Two more questions quickly, Brian, in the interest of time. I don't want to place one over the other. Can stroke symptoms occur on both sides of your body? And secondly, can stroke patients fully recover?
Can stroke symptoms occur? Yes, depending on the location of the artery affected, you can have stroke symptoms on both sides of the body. So they don't always have to be on one side. And yes, patients can fully recover. That's why it's so important to act quickly if you recognize in yourself or in a friend or loved one the signs or symptoms of the stroke, as we elucidated. Call 911, get to the hospital, and there are treatments, whether those are medical treatments or procedures that can be done that can reverse the causes of stroke, and patients can have a complete and full recovery.
Guys, this has been really extremely informative, and I really want to thank you guys for sharing all these insights with our audience. Remember, viewers, you can connect with us on all the social media channels. That's Facebook, Instagram, Twitter, LinkedIn, and check out our resource blog for the latest news at baptisthealth.net/news. That's baptisthealth.net/news. You'll find a link there to all episodes of the Baptist Health Podcast as well. That's the Baptist Health Talk Podcast. On behalf of everyone at Baptist Health, we ask you to please stay safe, do your part to stop the spread of COVID-19, mask up, South Florida.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Resource Live is brought to you by Baptist Health South Florida. Healthcare that cares.